Okay, so picture this. Someone has a chronic illness, something they're managing, and then suddenly it just explodes into a life-or-death crisis. That's what we're talking about today. Acute-on-Chronic Liver Failure, or ACLF. This isn't some slow, gradual decline. No, this is a full-blown medical emergency where the body's systems can just start shutting down in a matter of days. Let's get into what makes this so incredibly dangerous.
I want to start with just one number because it tells you almost everything you need to know. 77%. That's the 28-day mortality rate for patients with the most severe grade of ACLF. It's a staggering figure that just hammers home the urgency here and why we need to understand this devastating syndrome. So in this explainer, we're going to break it all down. We'll start with what this sudden deadly syndrome actually is. Then we'll get into its weird identity crisis, why doctors can't seem to agree on one definition. We'll look at the triggers that set off this storm, how it's managed in the ICU, the really tough decisions around transplants, and we'll end on a positive note, the new therapies that offer a real horizon of hope. All right, let's kick things off. What exactly is this sudden and deadly syndrome, and what makes it so different from other kinds of liver disease?
You know, the key is really right there in the name, acute-on-chronic. This is something that happens to people who already have long-term liver damage, usually cirrhosis. So they're living with this chronic condition, but then some acute event, like a simple infection, comes along and flips a switch, setting off this catastrophic domino effect. All of a sudden, it's not just the liver that's in trouble. Other organs, the kidneys, the brain, the lungs, they start failing too. And that is what makes ACLF a whole different and much more dangerous ballgame.
So you'd think for something this serious, we'd have it all figured out, right? Well, that leads us to one of the biggest challenges in fighting ACLF. Believe it or not, doctors around the world don't actually agree on what it is. And that really boils down to this question. How do you fight an enemy when it seems to have three different faces? That's the problem facing the medical community. Because if you don't have one single universal definition, it makes it incredibly hard to research it, diagnose it, and of course treat it effectively. And this table just lays the problem out so clearly. You've got these three main definitions from Europe, North America, and the Asia-Pacific region, and they disagree on really fundamental stuff. For instance, the North American definition says you need at least 2 other organs failing, not just the liver. Meanwhile, the Asia-Pacific one focuses more on classic liver symptoms, like jaundice and blood clotting issues. These are not small details. This confusion makes it almost impossible to compare studies from different continents or to develop treatments that work for everyone.
So, if these patients are already managing a chronic condition, what's the tipping point? What is it that suddenly pushes them over the edge? Let's take a look at the triggers of this storm.
In Western populations, the main culprits are pretty clear: alcohol-related issues and bacterial infections. Together, they make up the vast majority of cases. But here's the part that's kind of spooky. Look at that last slice. In almost 1 out of every 5 patients, doctors can't find any specific trigger. The body systems just crash for no obvious reason at all.
But no matter what the initial trigger is, the body's reaction is the same. It just unleashes this massive, out-of-control inflammatory response. You might have heard it called a cytokine storm. Basically, instead of a targeted attack, the body's defense systems go completely haywire. It's like calling the fire department, and they show up and start spraying gasoline everywhere. This friendly fire is what ends up damaging all the other organs and causing them to shut down.
So once this storm hits, how on earth do doctors even begin to manage the chaos? Let's move into how this crisis is handled in real time. In the intensive care unit, it is an absolute race against the clock. Step 1, get the patient into an ICU, preferably one that can do a transplant, like now. While that's happening, doctors are on a frantic hunt for the trigger, usually starting powerful antibiotics right away just in case. And at the exact same time, a whole team is working to provide life support for every single organ system that's failing. This thing changes so fast, so the team is constantly reevaluating the patient's chances, sometimes every few days. And this is what that all-out effort looks like in practice. If the kidneys fail, the patient might need dialysis to clean their blood. If toxins start building up and affecting the brain, that's a condition called hepatic encephalopathy. They use specific medicines to clear them out. If blood pressure completely tanks, they use powerful drugs called vasopressors to keep the blood moving. And of course, if the lungs fail, a ventilator has to take over the job of breathing. It's just a constant moment-to-moment battle to keep the body's most basic functions online. But here's the hard truth. Even with the absolute best ICU care in the world, there is currently only one cure for ACLF, and this brings us to the transplant dilemma. Now, for the patients who are strong enough to get a liver transplant, the results can be just incredible. the 1-year survival rate is about 80%, and even 5 years down the road, it's holding steady at 70%. This is a huge message of hope. It proves that transplantation can be a real life-saving fix.
But, and this is a big but, here's the dilemma. As good as those numbers are, they're still a bit lower than for patients who get a transplant for other, less urgent conditions. You can see the gap right here. ACLF patients are just so much sicker, so much more fragile, and that makes the surgery itself much riskier. And this creates a really profound ethical challenge when it comes to deciding who gets a life-saving organ. It all comes down to this unbelievably difficult decision for doctors and transplant committees. There just aren't enough donor organs to go around. So who gets one? How do you weigh the higher risk of giving an organ to a critically ill ACLF patient against the fact that they will almost certainly die without one? Every single case is a complex judgment call, looking at things like age, overall health, and whether they have active infections.
But what if there was another way? What if we could treat ACLF without a transplant? And that brings us to our final section, a true horizon of hope.
Researchers are exploring some amazing new ways to step in. We're talking about things like liver dialysis, where a machine outside the body literally filters out toxins. Another cool idea is plasma exchange. It's like giving the blood an oil change, taking out the harmful stuff and replacing it with healthy plasma. Beyond that, scientists are looking at stem cells to help repair damage and even developing new drugs that can specifically target and calm down that inflammatory storm. Now, these aren't cures just yet, but they could one day act as a bridge to keep patients stable enough for a transplant. Or maybe, just maybe, become an alternative altogether.
So in the end, ALCLF is a syndrome that really pushes modern medicine right to its absolute limits. But as our understanding gets deeper and all these new therapies start to emerge, we're left with a really hopeful question. Can we finally turn this deadly, lightning-fast crisis into something that's chronic but manageable? The ultimate goal isn't just to fight the fire anymore, but to find a way to control it, giving thousands of patients and their families a real shot at a future. Thanks for joining me for this.